Hello, my name is Tomas Amenabar, and we would like to present this surgical technique video. We have nothing to disclose regarding this surgical video. A blunt cannula with a trocar is advanced from the anterolateral portal, and a blunt switching stick is introduced through the mid-anterior portal and is triangulated into the extracapsular space. The muscle interval between iliocapsularis and gluteus minimus is cleared, and the reflex portion of the anterior rectus is identified as an important landmark. The muscle interval is clearly visible, the articular capsule has been cleaned, and the reflex portion of the anterior rectus is identified to the left of your screen. With the reflex portion of the anterior rectus as a reference, a longitudinal capsulotomy following the axis of the femoral neck is performed. After completing the capsulotomy, we achieve an excellent view of the hip joint without the need for traction. The femoral head, labrum, femoral neck, and both the anterior and posterior hip capsule are easily identified. Once this is accomplished, traction is applied, and intra-articular exploration is performed. Viewing from the anterolateral portal with the 70-degree scope, we are able to evaluate the whole central compartment and labrum. We begin with pincer correction, working from the dalla portal using a burr. This allows us to remove the pincer deformity by operating underneath the capsule without causing damage to it. As we move to the lateral and posterior pincer, the same principle is applied. Using the burr from the dalla portal, we are able to address the pincer deformity without compromising the integrity of the hip capsule. Following pincer correction, the anchors are inserted for labral repair. My preference is to use the dalla portal for anchor insertion as it provides better and safer orientation, resulting in an improved labral repair. While there are several options available, I prefer using small curved anchors with knots to perform the repair. Depending on surgeon preferences or labrum characteristics, labral base or simple stitch could be used. I always aim to tie the knots without traction to ensure a proper seal. As a final check, I verify the suction seal by releasing and reapplying traction to confirm its effectiveness. The burr comes from the mid-anterior portal, and longitudinal orientation of the capsulotomy along the neck provides excellent visualization of KM deformities for correction. This can be optimized by adjusting the degree of flexion and rotation of the extremity. A challenging aspect of KM correction is reaching the most lateral deformity on the neck, which is in close proximity to the retinacular vessels. With this approach, when lateral correction on the neck is needed, a switching stick or a microfracture awl could be used as an arthroscopic elevator through the dalla portal. The goal is to separate and lift the lateral capsule, allowing for excellent visualization of the lateral deformity and the entry of the retinacular vessels. Capsular closure is performed with side-to-side sutures. As the pericapsular tissue was cleared prior to the capsulotomy, the visualization of both the anterior and posterior capsular flaps is optimal. Various techniques and instruments can be used for this closure. I prefer using a suture passer from the mid-anterior portal to penetrate the anterior capsular flap and an automated grasper to capture the posterior capsule, passing the other end of the suture. Closure is performed from proximal to distal, typically achieving a watertight seal with the use of 3 sutures.